Oh, and I think we're live. We're live. Welcome, everybody. We're going to have a panel, a fun discussion, and answer questions about modifying the treatment for OCD in the context of COVID-19. And why don't we start with our panelists introducing ourselves? Jason, you want to start us off?
Sure. Thank you so much. Thank you, everybody, for joining, and glad everybody's able to come together to have this discussion. My name is Jason Spielman. I'm a licensed psychologist in South Florida, and I'm the clinical director of the Anxiety and OCD Treatment Center of Florida. Been in practice for almost 20 years now, and very active with the IOCDF. I'm on our Central and South Florida board in South Florida for the IOCDF, and do a lot of lecturing and talking and see patients quite often throughout the day. So thank you guys for all having me.
Sony?
Hi, I'm Sony Khemlani. I'm similar to Jason. I am a licensed psychologist, except in Great Neck, New York, at the Biobehavioral Institute, where I've been doing clinical work and supervision and all those good things, treating OCD, BDD, and the whole gamut of OCD-related disorders. I'm also the clinical director there, and I'm on the board of the OCD New York, which is the New York affiliate of the IOCDF, and on the scientific advisory board of IOCDF as well. So thank you for having me.
Awesome. Jon?
So I'm Jon Grayson, and I've only been working with OCD since 1978. So I'm a little new to it. Currently I'm in California, where I'm at the Grayson LA Treatment Center for Anxiety and OCD, and very active with the International OC Foundation and giving presentations. And strangely, after that many years of doing it, I still love doing this.
Cool. And I'm Jon Abramowitz, and I am also a licensed psychologist. That makes four of us. I'm at the University of North Carolina. I do research, I also teach, and I do private practice work as well, with primarily with people who have OCD. And we don't have any questions yet. We definitely want questions, so please, if you're out there watching us, please ask us questions. But I guess to start off with, why don't we just kind of talk a little bit about it, like among ourselves. I don't know, any thoughts about kind of modifying the treatment of OCD in the context of COVID-19. We were talking a little bit before we started about how a lot of us who have worked with people with OCD, they're actually faring quite well. I don't know, anybody want to talk about specific, people that they've worked with and kind of observations that they've had about how their patients with OCD have been faring in this environment?
I don't mind repeating what I said before we had viewers.
Yeah.
I've always said to clients that, when you overcome OCD, you won't be normal. You will be better than normal. That normal people don't really cope that well with uncertainty. And my clients who are doing well have found that to be the case. They kind of sit in awe of the fact that their families are way more messed up and having difficulty than they are. So that's kind of pleasant for them in a way. I mean, it's kind of difficult. Some of them are. One fellow who had severe contamination problems, who's doing very well, he's looking around at all the normals, doing things that he used to do, and he said to the group, I feel like I can see all the ways that they're screwing up. I feel like I should hire myself out to help them perfect their rituals. But he hasn't gone professional yet with that. At the support group, because we've been holding it via Zoom, there were some people who did need some help about how to modify treatment, that there is, because there's so much information. And I think all of us have said this, it is really important to not watch everything on this because there is a lot of conflicting information. I really try to have people narrow it down to good sources, because even watching a local news channel with a medical professional who might be kind of reputable, they often deviate from what the CDC says, and so I'm kind of encouraging people to watch a network that's just doing CDC primarily, and at most twice a day for 15 minutes, because again, people will regularly go beyond. So in the support group when we were running, part of what we were doing was education. Like, here's what the CDC is saying. Here's what we think is, way above and beyond what the CDC is saying. And I could be more specific, or I could, where we can get to that later.
I was going to say that I've run into the same thing for folks I've worked with OCD and other problems with anxiety too. It seems like they're getting into more difficulties, more trouble with watching the news, which is feeding into their uncertainty, than doing rituals like washing and avoidance and things like that. I don't have OCD myself, but I find that I have to take a break from the news also. Today I actually did that. For me, it's more just I get my blood boils with all the way it's become political. But it's true that there's so much, different information. You can really get anxious by not knowing what's what. And of course, our friends with OCD, they're the ones that are gonna, with their negative threat biases, right? They're gonna pay attention to the most conservative estimates and suggestions and the most anxiety provoking, news stories and information.
I actually find a lot of them aren't, for myself, like some of them, like this was really gratifying. Like, they're finding a pain in the neck to wash their hands for 20 seconds.
Huh.
So yeah, the thing that has scared them most currently is hearing that I'm washing my hands, which I hadn't done since 1979.
Right.
But
so
really,
we have a couple of questions. Any guidance is appreciated. I have 2 patients with scrupulosity who are struggling with gathering limits. So minions, right, where you have at least 10 Jewish folks have to be together for a minyan, or else going to church, and how God's going to judge them or hate them for not going to these services. Any thoughts about that?
That's actually an easy one at least with regard to minyan, because in Judaism, it's very specific that health comes first. I mean, if I'm a physician, somebody needs me in an emergency, I can drive my car there as an Orthodox Jew, because health always outweighs everything. I can eat, there's a reason I have to eat because I'm sick or whatever. So that would normally not be a problem. That wouldn't be a problem technically for the Orthodox.
Right. Yeah, your health is supposed to come first.
Right. So they would actually be violating the law by doing that, which sometimes people with scrupulosity do, but it's like that would be a violation of the law technically, since health has to control everything. I hate to use it that way.
Yeah. Other thoughts about that, or about going to church?
Well, I think people can choose to pray and have faith in any way that they choose to. The building really doesn't define, I think, your faith and what you're sort of praying for. But I could see that the change of not being able to go to the church or to the temple can be a little overwhelming for people.
Agreed. You have to validate also that they're lacking that social connection that comes with going, and the routine and the structure that provides. Hopefully some of the synagogues and churches are live streaming or doing virtual, praying together too. So that might help for patients.
And I think also, like we were talking about before, everyone's in the same boat, right? So no one knows if God is going to be pissed off at them for not going to services, but I guess we're all going down together these days. Except for that one, there was that one church, was it in Georgia or Alabama or something, where some crazy pastor was, I don't know. We have another question. Oh, were you going to say something, John?
No, I'm just laughing with you, John.
Okay, there's always somebody out there. So another question. So the CDC advises to wash hands frequently. Of course, this leaves a lot of room for interpretation. What specific guidance do you give regarding the frequency to wash, and under what circumstances? Great question. What do people think? I've had patients ask me that.
Yeah, I think I would follow what the CDC says. I think so far they've been staying pretty steadfast at the 20-second rule with washing. But when it comes to OCD and contamination, I mean, somebody can have the urge to have to wash over and over and over again, but it doesn't really have to do a lot of the time with COVID-19. It could have to do with it didn't feel right, or I had the wrong thought when I was doing it. So I think separating the OCD versus the CDC is, I think, a good idea. And I've had a lot of my patients keep an OCD versus CDC list. And so they're trying to sort of see the difference between one and the other, and they're comparing the two.
Yeah.
I mean, in a sense, it's a simple question when you say to do, as Jason said, follow the CDC, because for my clients, it's like, okay, fine, do the 20-second wash when you enter the house. Once you've done that, there's no reason to wash your hands after that. So in the house, we're doing contamination. In the house, that also means contaminating others. You know, I've heard some reports of patients like, you know, somebody was just, I can't share that. But somebody was worried about contaminating, you know, like they'd wash their hands, and then they were like, they didn't want the family to touch some things. And it's kind of like, if you've got COVID-19 and, you know, you're not doing the 14-day isolation, they're getting it. You know, I mean, you know, so it's different from whether I have it or not. But in terms of bringing in just that, you know, that 20-second hand wash, not a shower, you know, CDC, don't take off your clothes. So all those things become simple. And now all the other things that we want them to do that are horrible, they can do that at home, and including with regard to spreading it. So we are following a CDC. Yeah, fine, walk in the house like this and then wash your hands just for 20 seconds, which, you know, it's more than we want, but it's an exposure if I have bad contamination, because, you know, we have to point out to people, you're not going to feel good. Like, you wash your hands for 20 seconds, it's not going to feel good. And it works pretty well.
That's the goal. Yeah. And actually, we had related to that, to what you said, John, we had a question about what about advising people who are worried about contaminating others versus contaminating themselves. And I think you hit the nail on the head there too.
Right. They can still now, you know, rub the toilet and spread it all over the house.
Yeah.
I think that I was thinking about this last night, just in prep for this. And I think they're also, just as a psychologist and treatment providers, we should look at also liability issues. You know, just in terms of, like, we live in a gray area sometimes in terms of treatment that we do, exposures and things like that. But I think there are potential liability issues when you're asking somebody to go do exposures, especially in the context of a pandemic. And we just have to be careful, I think, how we approach that. I'm not sure what the others think, but I think just being mindful of this and mindful of the patients that we have in terms of how they approach some of their exposures would be really important.
Well, I mean, you're absolutely right. I mean, pretty much almost every exposure I would want to do outside the house,
sure,
you know, outside that safe area, I can't do right now.
Mm-hmm.
You know, so that doesn't, you know, so we can't do it as effectively, but that's the liability incurrence safe thing to do. You know, so there's a bunch we can get. I mean, what we get to do is greatly reduced, but that's like the fact of life for everyone.
We've been corrected. Someone pointed out that the church was in Louisiana where they had the standoff. I think, yeah. So I appreciate that. Okay, a little bit of a different topic. So parents' behaviors. So when parents aren't being cautious enough for the person with OCD, so they're not, you know, properly cleaning packages or getting too close to others or things like that. Any advice on how to work with? And I guess I'll kind of open this up to, like, family stuff. What if, you know, the person with OCD wants to be very, very careful, of course, about these things, but then parents, maybe brother or sister, other people living in the house, they want to be a little bit more, you know, liberal about these rules. What do you think?
I think just going back to the CDC and, you know, World Health Organization and pulling up that information and kind of working with the family on what's going on behind that dynamic. I think a lot of patients with OCD don't feel like the rest of, you know, the family understand, and they struggle with that. And, you know, so they get dismissed, like, oh, there you go again with your OCD kind of rules. Whereas you have to be validated and taken seriously at this time, that not everything they're saying is coming from an OCD perspective.
But actually, from a non-pathological point of view,
yeah.
I am having patients where, you know, the family is completely not doing it. Often it's not family living with them. Like, they're here and my parents are in another state and my parents don't take it seriously. You know, and so it's, you know, so it's not even, you know, it's just like, I think various people are having this problem. And of course, you know, I said for my clients, some of the parents are way beyond CDC, but for the ones who aren't even following that patient, well, whoever is asking that the parents be better is stuck accepting you're not going to be able to save them.
I think also just in regards to John, I agree with what you're saying very much, and Sony. But I think on top of that, there's a few silver linings to this horrible circumstance that we're all in. And one is that we're able to now have like an open audience for families, especially parents, where parents are often working when I see the kids and otherwise. And I've actually incorporated a lot more family and parent support for the kids. And not only explaining what the kids are going through and helping support them, but helping train them as therapy support advocates to be able to work with them while in the house. And I think that's been really helpful to be able to do on a regular basis now.
Yep.
That's a great point. And helping with that communication and with how to be able to get on the same page in terms of sharing thoughts and feelings and kind of listening and putting yourself in the other person's shoes, being able to compromise and negotiate, especially since everybody's crammed in together right now. I think those are really important points. A little bit of a different topic. So one person is writing in saying that they're struggling with making group sessions engaging online at this point. Any recommendations? Great question.
Mm-hmm.
I've been running my support group. Yes, online, using Zoom. And Zoom is kind of pretty cool because, at least, I don't know if it's all the free version, but the $15 a month version, because in my support group, I also break into small sessions. I break the group up, and it has a breakout room feature. So, I start my group with 25, and then after about an hour, we break into small rooms, and I bounce around from room to room. I actually had to limit who could come because so many people who don't feel like driving in LA would suddenly be willing to come. So we had to put a bit of a limit to make sure we didn't get overcrowded. So Zoom is a great platform from that perspective. I don't know if they're having some other difficulty getting a group on, but if it's platform, that's it. I haven't had any trouble getting people to come.
One of the nice things I like about Zoom is you can put a fake background behind you.
Yeah.
And actually, I've been on some Zoom calls where like they had a little game where you can come up with the best background, or they sent around a picture and everyone had to have the same background. One of my daughter is home from college now, and one of the classes that she was taking, somebody sent around photos of the professor from when he was a little boy, and everyone had a different photo of the professor as their background. So they, kind of made it funny. So, that's not an OCD related way, but it's just some sort of way that something that people can talk about and bond on, and I don't know.
I wouldn't do it for individuals, but for the support group, there was a dynamic background of the northern lights that are flickering. Yeah. So there's my head with this incredible godlike background behind me. That was fun. Yeah,
you can be in space, you can be, on the beach, all those things. And then that's something that people can talk about if they want to have that as their background. You spend a few minutes talking about the background, break the ice, and then maybe makes it easier for people to jump in. I don't know.
Yeah.
I think you could do like a weekly goals group where you set specific goals for each person and they can touch base one week after the other. If you have enough people, you could also do a psychodynamic group where everybody's like doing some type of activity together that's either anxiety or OCD related. And there's a lot of different activities that you can do. And then also, I think you can also pull some type of poll. So if you have like a Facebook page, or I'm not sure, John, maybe, on Zoom, if they could do this, you could send around a poll for what people are sort of struggling with the most to bring up topics and to be able to talk about it as a group together.
I love it. There is a feature where you can, send a document around Zoom. Can they answer the poll? I'm not sure. I think it's doable, but there was a chat thing, so people could send you responses. Actually, you could ask something, and there's a chat box so everybody could send the answers to the host. I think everybody can see them, or that's your choice as the host.
Okay.
People are pointing out just to watch P's and Q's with regards to confidentiality if you're sending emails around. Things like that as well. Another question. I have patients preoccupied with monitoring physical symptoms. They're terrified by uncertainty that they've contracted the virus, COVID-19, but they are not fully symptomatic, right? But they can't stop worrying about it. So, I think that this is where there's certainly some overlap with health anxiety or illness anxiety, like they're, calling it now, what used to be called hypochondriasis. But again, more uncertainty. What does the panel think?
Well, there are two issues, right? One is the issue of getting the illness, and technically, me getting the illness generally is not a problem because most of us are going to be okay. Like in your age group, John, 2 in 10,000 chance of dying. So, you're like pretty good. My age group, it's 3 in 100, but that's still pretty good. But I mean, but for most people, it's not that it's harmless, because some people will say, but, because the news will always show, but this young person died. And it's like, yes, you could die. It's not like it's not serious, but the thing is about monitoring, it's not going to help you at all. That is, in terms of monitoring, it's not like we have the early warning. And if I find out I got this treatment, if I find out early, they're going to save me. It's like, you're just, but first of all, if you have early symptoms, but you're not symptomatic enough, well, no one's going to test you. So great. You'll call the doctor and they'll say like, yep, maybe you have it. I have a few clients where that happened. The doctor said, well, yeah, you probably have it. Mm-hmm. And that was it. That was the end. No treatment, no nothing. So there's no, it's pointing out like, because I think part of the fear is like, what if I get it?
Right.
I think handling all uncertainties, yes, you might have it. And, yes, we keep, what will you do if you actually have it? What do you have to do? And, and now the other issue, of course, is what I have it and I spread it. And that's another whole issue. And it's like, if you have it, if you have it in your house, if you suddenly have it, well, your family's probably got it. Right? I mean, by the time you're potentially having symptoms, you've been walking around and sharing it with them. So in a sense, I'm saying you don't have to worry about it because it's too late. And right. So, and all uncertainty in coping with it, it's not like, the answer is always, whatever the worst happens, how will you try to cope? And all worrying is like, no. And it's like, this is the possibility. And if you have it, well, they're going to let you have it.
Right. I've been saying to my patients, the safest place you can be, even if you have it, is home, because the doctors are saying to us, if you enter that emergency room, if you don't have it, you put yourself at tremendous risk for contracting it. So unless, you're in danger of having breathing difficulties, stay home. Yeah. It doesn't make a difference.
And I also actually ask a lot of my patients, most of the time they're very ego dystonic about a lot of the things that are going on. And we just really try to tend to focus them on orienting towards things they could do, actions they could take at home that don't conflict, obviously, the CDC recommendations, but obviously that don't support, their OCD compulsions or, obsessive thoughts that they're struggling with at the time.
Yep.
Let's see, what else do we have here? Send in questions. We need more questions. Here's one. I heard that you can't send the fake that was, we talked about that. We're talking about fake backgrounds and confidentiality. Advice for patients preoccupied with monitoring their physical symptoms. We were just talking about that. I'm asleep at the switch here. We need more questions. We know that we have plenty of people.
I did see one question that got lost. Somebody was asking about washing some more, and they were saying, the CDC is saying wash before you eat and wash handling mail. And, I think there are a few answers to that. Washing before you eat, certainly if for some reason you're in a place where they're not on lockdown, if I was going to my office now, and this pains me to say it, I would wash before I ate because people are coming in my office and, and really in my office, which would be pretty safe in a lot of ways, but the main reason to wash my hands, any extra, would be you stick your hands in your mouth and you don't know, and so maybe I'm contaminated. At home, that's not an issue. At home, well, what is your food? I mean, clearly, if I want to protect my food, great. When I get my grocery delivery, so I stick it in a corner and let it sit for 3 days. I no longer have to then wash before I eat. And I can I can put the produce in the fridge and let it sit there for 3 days. But, so I don't have to necessarily wipe everything down, and all that. And CDC says wash vegetables just with cold water, but that's presuming they haven't been sitting for 3 days, letting it die. Now you can read more stuff and make yourself crazy. But so I don't really have to wash before I eat at home because, and again, CDC says wash after going to the bathroom, but I really think they're kind of sticking something on there because there's no evidence you're going to get, COVID-19 from it in the bathroom, because basically if it's in your body, when you're going to the bathroom, you probably have it and you're spreading it anyway. So it's still that kind of home is magic and I don't need to do those extra things.
And if you're going to get really picky about it, I mean, the CDC, they don't know, that when they say, 3 days, right? Or wash your hands for 20 seconds, right? I mean, almost certainly the virus doesn't live for exactly 20 seconds, right? Or it takes more or less than exactly, that's a round number. So, I mean, these are just guesses as well. Now, they're informed guesses, but that, I think there is leeway, and with our patients, we can help them to see that if you wash for 19 seconds and not 20, you're still going to be okay. If you, those rules are still, there's still uncertainty around them as well. I was going to say something else, but I lost my train of thought. But now we're having some more questions, so thank you all. Question from Jed Steve. Hey, Jed. So in terms of it being too late, if you have it and have been around family, what about patients who point out that load is associated with severity of illness, such that more exposure means more severe illness?
That particular statement, if I understand it, I have not heard any evidence to that effect. That if I'm around it more, my illness will be more severe.
Worse,
yeah. That the more COVID-19 I'm around, the worse I'll be. I haven't heard that, so I don't know.
That's been speculation because healthcare workers are getting it, and so I think again that's what the news does is they present the facts and then they start to speculate, and it's that constant conversation.
Yeah, so I don't think that's I think that's right. I think you're right. I don't think that's currently a fact.
I don't know. Yeah.
Certainly being around it more often makes it more likely for me to get it, but that's a different kind of issue than Jed's asking about.
Mm-hmm.
There's another question, which is also a great question, about general stress. So, aside from specific OCD treatment, exposure and response prevention, I'm curious if you guys are doing anything about just kind of stress management, exercise, watching your, diet, your sleep, things like that. I've actually found those to be useful suggestions where I typically don't give them a lot in treatment with folks I'm working with who have OCD, but now, especially since we're all cooped up in the house, I'm telling them, go out, go exercise, get good night's sleep, things like that. I don't know. What do you guys think?
Absolutely. I'm preaching all those basic things. Create a routine at home, get up at the same time, within a normal daily routine, get out, play board games, binge on Netflix, anything that helps you, in a healthy way cope.
Yeah.
I think with a lot of my patients, I've tried to, in each of the sessions, not each, but when we started this whole process, we've all started telehealth, I've reset the goals that we all have with people. And, since life is different right now, and I guess the concept of treatment should adapt a little bit, and that the series of goals that we have should be, I think right now, focused on short-term and more long-term goals that we're going to have getting through this process of COVID, and also what do we do when it's over as well. And, OCD obviously is a huge component, but there's a lot of other things I think like you're talking about right now. And some of them are how we adapt in this process. And I think like Sony was just saying, a lot of the kids, and maybe it goes to this next question, but a lot of the kids have so much free time, an overabundance of free time now. I have 2 kids at home, and both of them are supposed to be in virtual school, but the school is, a few hours a day. And there's so much extra time. So a lot of the patients that I've been working with, we've actually sat down and created, like Sony was alluding to, 9 o'clock in the morning, 10 o'clock in the morning, 11, keeping that routine going, I think is really important, because we've found obviously a lot, when people have a lot more time, OCD sort of rears its head and gets a little bit stronger with isolation and excess of time. And I'm not sure what routines you guys have tried to incorporate with a lot of the patients you've been working with.
I think what Sony said was really important in terms of creating routines. I said, first few days my wife wasn't getting dressed, and it's like, okay, I think I better get dressed in the morning, and but having routine, but also having some variability. I mean, yes, Netflix and binging, what else can you do that might be meaningful? Now, for some people, they are things they like to do that, I'll also occupy them. For others, the same problem we've had with them all along, like what else is important in life to you? And it's kind of like, if nothing's important, okay, you're gonna have to try things we don't even know if they're gonna work. I think with kids, routine's really important. I have this 5-year-old grandson, and my kids have done wonderfully with him. And I think the structuring of time with kids means a lot of work for the parents. So he's 5. He's having a great time. I think his pandemic memory. Well, because it's they break his day up. There's video game time. There's this time, and and there's all these times, including a free time. And they've turned their house into a magic place. Things that the entire house is emergency town.
Yeah.
Likes emergencies. There's the hospital in it. Nothing to do with the pandemic, but so I think for kids, trying to set it up, it's kind of like your summer camp, and you've got to make the entire program. So, in a sense, way easier for the kids than the parents. Yes. So many parents I think are finding we need to raise teacher salaries.
Absolutely.
That actually dovetails nicely with Jeff Szymanski's question about making modifications for kids. Maybe if we can talk more specifically about exposures and response prevention. Any differences with treating kids and with treating adults? Cricket.
I'm silent. I don't work that much with kids under 14.
Yeah, neither do I. Neither do I.
I work a lot with kids, and I think it's like we were talking about before, being able to incorporate some daily schedule for them is really helpful. Being able to have the parents get involved, but it's a hard thing. You're having parents who, the posting just came out today, 10 million people, have claimed that they don't have jobs now. And, a lot of people are at home. So getting parents involved as much as you can in the process of treatment and just supporting their kids at home. I think like Jon and Sony were talking about the activities at home. My kids have been, outside, and we've started gardening, and, they've been in the pool or in Florida. So it's a positive thing. But just having activities that you could do with them, and obviously being able to explain to them that everything has not only a beginning, but also a middle and an end. And, this too will pass as well. And I think a lot of the kids are afraid, but they show it in very different ways than adults would. My kids are, one of their main topics is not only not finishing school right now, but is this going to last into the summer? What's going to happen with my summer? Am I going to be able to see my friends? When am I going to be able to do that? So it's scary for them as well.
Yeah. It's interesting because I'm thinking I treat a lot of kids and adolescents, and they're handling it much better than I thought. And for some of them, taking away school stress has had a tremendously positive impact on them. Don't want to do sessions right now. They're handling it quite well. It's the parents, I think, that are having the harder time.
Yeah. Question from Lori: how do you handle patients whose OCD has always been about germs? The germs are everywhere. Now the government is confirming that their OCD seems to be true. We've kind of talked about this a little bit, but how could we help Lori?
I always tell clients a few facts about that. First of all, germs literally are everywhere. We actually know that. The house is filled with germs. There are about a few 100,000 varieties of germs that are floating in the air that you are breathing in every minute. Vast majority of them harmless. A smaller portion of them are actually necessary. So you actually could successfully disinfect the house, you're going to die. And then a small part are pathogenic. And the thing is that germs survive in every environment. So your house, literally, and your heating system are the same germs that live in the hot ocean vents. In your fridge, same germs that live in the Arctic. So even if you disinfect an area, whatever you're killing, you're making it hospitable to something else that may or may not be good. So the issue isn't that, germs are everywhere. Yeah, they are everywhere, and trying to get rid of them will actually hurt you. The issue is there are some bad germs, and most of the time, yes, you're at some risk, but low enough that OCD is worse than that. Here we have the one exception. So if you've been spending your whole life in misery in preparation for this, it'd be really sad because this wouldn't be any better and you'd still be at just as much risk. So you would have missed right 2 to 20 years of life in preparation for this, and same with after. So it's not that it's, again, what are the odds? And yeah, there's uncertainty, but germs are everywhere. You can't actually kill them all. And
this is just one more type of germ.
If you kill them all, you're likely to be dead because some are necessary for your survival.
There's a lot of germs that are actually very positive for us and do really good things for us. And so, I mean, like Jon was saying, you don't want to kill them all. In this case, it's a little different. But I think also the concept of being able to work on what is OCD versus what the government is saying are very different things.
Yep.
Right.
In some ways, my advice has not changed. I think if, say, I have a patient who hasn't left her house in 10, 12 days, and she's sitting on the couch, and all of a sudden she gets this rise of anxiety, and there's just this intrusive urge to go wash her hands, so she'll go wash. And that's very clearly OCD. She hasn't left her house. Nobody has come home over. Or if your hands are cracked and bleeding, then the germs are more likely to enter. So some of the things I've always said to patients, I'm continuing to say, even within this context.
I find myself doing the same thing, and kind of related to that, clients preoccupied with the idea that before she sheltered at home, she may have exposed people to COVID, and now she's unwilling to do an exposure script. So help with working with someone who's resistant to doing exposure. Again, probably going to be pretty similar to how, someone who's resistant to doing exposure before all this brouhaha.
I think with exposure, right? I mean, our treatment is really pretty simple. I mean, we need some knowledge. The real trick and magic of doing ERP is helping the person agree to doing it. How do I, what do I present? And I think one of the powers of talking about uncertainty is it's not like you actually have a choice. Ultimately you're going to do exposure because it's not like you have a set of rituals that are going to work. So the worst might happen. And so it's a variation of that for this. And, so I think on one hand, it's exactly the same as you said, Jon. And on the other hand, it's very individual to each client. What's the little key I can find that's going to help break them open to, I might as well take the risk.
I think you take a step down the hierarchy and sort of redefine the hierarchy a little bit more. If they're not willing to do that script or whatever it might be, they might be more willing to do something else that's less on their SUDS level and a little bit easier for them to start with, and you sort of build back up again.
Yeah, I think then you target the disastrous, whatever the core disastrous consequences are of being responsible or hurting somebody else, and just attack those core beliefs in a different way.
This is my own, actually, question out of curiosity to the group. What are, if anything, what are you guys telling patients about your own practices with dealing with all this? Like self-disclosure.
I always self-disclose too much, so I'm willing to tell them what I do.
Oh, really, Jon?
I know it's a shock. So I tell them what I do, and they can see the pain in my face that it's like, I can't believe I'm doing this. So I'll tell them what I'm doing rather than pretending I'm doing otherwise. Yeah. I think it's somewhat helpful for them to see, I'm currently responding to this thing. People always say, is there a limit or what would make you stop? It's like, all right, the government's saying this and I'm going to follow this. I'm not going to, so I think it's critical to me.
I'm pretty honest and straightforward with all the patients I work with. They know that, we're cleaning stuff and wiping things down just based on what the CDC says. And, if they change their stance, then I'll change my stance also. But, we got a package today from Amazon something, and the package stayed outside. I wiped down, or I guess my wife wiped down, the package and wiped down the contents with a Lysol wipe, and then we left it alone for a little while and washed our hands. But I mean, I feel internally it's a little overkill, but I'm sort of going to go by what the guidelines are for now.
Yeah, and actually that dovetails nicely. Oh, Sony, were you going to say something?
No, I was going to say the same thing. I'm pretty open about myself, about what I'm doing. At times I kind of pause and say, because I'm, as an OCD therapist like all of you, I'm less likely to be cautious. So sometimes I'm thinking to myself, I don't want to advocate being too uncautious to some of my clients.
I find myself falling into the same position. And one of the things that I love as a CBT therapist is that it's totally okay to self-disclose and you treat the person you're working with like a colleague, in many respects, rather than in some other sorts of therapies where you're not supposed to say anything about yourself or your thoughts or stuff like that. So I value that a lot in CBT. There was a question that actually dovetailed nicely onto that, which we kind of covered, which is like, what are you telling patients to do about washing items from stores? And if you get stuff in the mail, anything else to add about that? Would you tell patients to do anything else than we said that we're doing ourselves?
I don't think so. I got to say, I found it very strange because maybe about 2 or 3 months ago, I went to a patient's house and one of her main things was going shopping. And she just came back from shopping, we went to her house, and she had to take her groceries from the car. And the exposure was just taking the groceries and putting them in the refrigerator. And it's just so surreal to be in this space where now that is the norm, that we're cleaning and wiping them down. And I had a session with her recently, and she's like, see, I was supposed to be doing that. And, so we talked about how the OCD played a role and otherwise, but it is a little surreal. I'm not sure if other treatment providers or therapists feel the strange aspect of this.
Yes.
Yes.
Definitely.
But again, I said, I'm doing the let it sit for 3 days, putting it in a clean bag and putting that in the fridge for perishables. But then I'm treating it as if it's clean.
Yeah.
Same with mail. I don't have to wash after the mail. We have the bizarre procedure. I'm outside the door carefully opening the envelope, not touching the inside and dumping it on the inside, and then Kathy takes it. Probably all of us, if we wanted to be OCD, we've had so much observation, we know how to do it right also. But beyond that, it's like if there's a greater risk above and beyond that, yes, we're taking it because, again, the other thing I point out to people is when we talk about flattening the curve, the government does not expect its procedures to prevent COVID-19, right? And those people get lost in like, this is going to keep me safe and my family safe. Right. Flattening the curve, it's kind of like we're pretty much expecting the same number of people to get the illness. We're just trying to spread it over the time. So it's not like I do all this and my family will be safe. I mean, it's kind of a disappointing, horrible thing to hear, but that's the implication of flattening the curve, not less cases. So if 20% is going to get it, they're thinking 20% are going to get it. It's just it's better if they get it over 10 months than in 2 months. So it's kind of the negative way of reinforcing not going crazy over trying to be so perfect because you're at best trying to work on a delay as opposed to you're definitely preventing it.
Another one of my questions, actually, because I've thought about going in this direction that I'm going to mention, and I don't know, maybe I have mixed feelings about it, but what about talking about how we know that this virus doesn't, for most people, it's actually not all that awful. It's like getting the flu. So like if you did get it or you gave it to your partner or spouse, as long as they're not, very old or compromised in some way, it's not going to be that bad. Well, I have a second part of that question, but let me leave it there and see what folks have as far as their reaction to that. Have you guys gone there?
Having them look at the data and say, okay, of the percentage of people who get it, a very small percentage, is it about 5% that get critically or seriously ill, that the other 95% recover well? I'm not sure about my statistics are accurate, but I think that's the number.
I think it might be a little bit like more people who don't recover well, but basically that's the idea that if you roll the dice, you're likely to be okay and recover. And again, I think that depends also on your age and, and your health.
Statistically, yes. Individually, of course, there are a number of outliers, but statistically, right? It's just Sony said it's not going to be that bad.
Go ahead. I'm sorry, John.
No.
I think the unfortunate, I think the unfortunate nature with that is a lot of the young adult patients that I'm seeing, especially like the teen and early 20s, are having the concept of I'll be totally fine. I don't care. I don't have to take precautions. And they're going to the opposite side of the spectrum with I can go out and most of the people that I'm seeing that are in their early 20s are still going out. They're still going on dates. They're still getting coffees. They're all those things, and they don't have the concept of actually that this is something that not only can harm them, but actually will harm other people that they care about.
Yeah.
Along those lines, I've had some people, they'll read a report about somebody 20 getting it, and then they see somebody young got it. And I said, I remind them, I said, we never said they weren't going to die. Like, it is dangerous, but it's, the odds are in your favor. But yes, you can get very sick. And yeah, certainly, well, you're in Florida. They don't listen down there. California, we're way better at listening. We took it seriously.
Yeah.
Well, we finally just closed down our state, so.
That's crazy. New York and New Jersey is crazy. We're in the hotbed, and we're a little bit more afraid, I think, than many other places.
So apropos to that, someone just wrote in and said, what would you say to a patient who is in a high risk group for OCD? Maybe comes and you're doing exposure with them. How might you treat that differently?
There's not really a way to treat it differently.
Stay home.
I mean, pretty much here in Cali, but I'm, pretty much everyone's staying home all the time. So, in a way, if I was in a high risk group, my behavior wouldn't change because I'm not really doing it. It's the same in terms of like, could this happen? Well, it's like any terrible thing we would talk about. Yes, you could die. I mean, this is I think for a lot of people with the fear of getting a lethal death, I never say it's not going to happen. And that's real, but it's more coping with the possibility this could really happen than what else you can do. I mean, you can stay in more, and like, if you have young families, if you have, adult kids who are going to work regularly, like, okay, you're not seeing your kids. So there are some precautions, but the idea of like, but I can't get in, it's like, well, no, you can. And just like I could wake up tomorrow and have pancreatic cancer, and like I can't do anything about that.
Yeah.
Yeah.
Other thoughts? The second part of my question was going to be that, okay, so even though we're all in lockdown, and well, if you look at the statistics, so I think worldwide anyway, we had our 1 millionth person today who got it. Well, there's like 7 billion people on the planet. And even in this country, there's not even 1 million people who have it in this country. And there's 350 million people in the country, or something like that. 300 million people in the country.
A lot.
So the risk now, again, it's different in different places. Probably in Wyoming, it's probably lower risk than in New York City right now. But the risk is still pretty damn low of getting this virus. No?
Maybe. No, I mean, some models.
Those are confirmed cases, I guess, that I'm talking about.
But here's the other thing. If the risk is higher, the fact is the risk is higher. In other words, it's like, because some models had it like, if we don't do the right things, it could be 30%, it could be 50% of the population will get it. So now the odds are like, oh, I could get it. But on the same token, outside, the following all the recommendations, the expectation is, oh yeah, but I'm probably going to get it. Or, so I mean, if it's higher, that's disastrous in a economic, sociological way. On an individual basis, it doesn't matter. It's not like, oh, the risk is higher, so now I need to do, there's nothing else to do. But currently, as you're pointing out, John, the risk is like pretty good. Probably you won't get it. Probably. And if that changes, and there's a whole variety of different models where it could change, but it's like, I feel like a broken record. Whatever the facts are and the way it's going, that's what we'll have to cope with. And the kind of denial way of like, but that can't happen. It's like, well, we have odds, but after the odds, that's it.
Yeah. Let's see. Questions, folks. Write in questions. Some people are praising our suggestions, so that's nice. Thanks.
I did see one question from earlier, since you're having trouble finding one, although I think
Go
this
ahead.
would be an easy one to answer. Jason didn't want to answer it. Somebody was curious what to say about clients who don't trust the primary sources of CDC due to distrust.
Oh, yeah.
And I mean, right, the answer is kind of, in a way, almost obvious. The only reason I'm going to partially trust the government is, in my mind, I can make up anything. I can see, even not being OCD, when I read some of the suggestions, I can see what I would think are potential flaws in why would that work. But if I take that path, then I'm going to live in an extremely, incredibly OCD way that there's no evidence that'll work. So it's not so much can I trust the CDC as much as it's the closest thing I have to potentially good data. Because if I don't trust them, it's not like, and here's the good source. It's not like, well, the most paranoid source is the best source. And of course, there are people on the other extreme who don't trust the CDC and think it's a bunch of malarkey. I don't need to do all that stuff. So I can have a wild belief system. This is the closest, for me personally, this is the closest I can get to data that I might be able to trust. I want to put it in the most negative way possible, because I don't have a better replacement if I don't trust them.
Yeah. Well put. I mean, I don't trust them. I mean, when I say I don't trust them, what I mean is, it doesn't mean I don't trust them at all. I trust that they're good minds thinking about it. Doesn't mean that they're absolutely correct 100% of the time, and we need to, if we don't follow their word 100% of the time, we're going to get the virus or going to be safe. Of course not. But when I say I don't trust them, I guess what I mean is I don't trust them any more or less than I would trust any other reasonable. They're imperfect. Let's put it that way, and we have to live with that.
They're just going by.
If they change your recommendation and go against something they said earlier, I wouldn't take it as like, darn it, I should have seen that coming. I knew it. It's like, all right, the data's changed and they're saying this, and all right, fine. My suspicion was verified. How many times was my suspicion not verified that I'm ignoring?
Right. Yeah.
I'm sorry, Jason, I cut you off.
No, I was going to say their attempts are to use data and to be able to make the best guesstimate that they can given the information they have. That information is changing all the time. And it goes back to the question you were talking about before, Jon, about the testing. We don't have, I don't think what they said right now, enough tests that are being done throughout the United States or quickly enough. So the data that they're going to continue to get is going to continue to change. Hence, the recommendations are going to continue to change.
Yeah.
Right. From a pragmatic perspective, I'm telling some of my patients, call your physician, call your trusted physician and get advice from there. If you don't trust other sources, there's probably a medical source you can trust.
I think a lot of the medical.
To me, that would be, because you could call 10 different doctors and you're going to get 10 different opinions in this kind of situation. What I mean?
I'm not going to turn into reassurance. Yeah. I would just say call your primary, your one person who's known you, and if you have that one source, rather than it turn into a reassurance kind of thing. Yeah.
The other thing that I've noticed is just this availability bias, right? Because we see, it goes back to my question, my thoughts about probability. You turn on the news and, CNN's interviewing this person who lost her husband, and there's a doctor who sees, this parade of people in New York, and they need the trucks that are the refrigerated morgues and all this. We don't hear about all of the millions and millions of people who are fine, right? And so you turn on the TV and you think the world is ending, everyone's getting this. And we know that people who have problems with anxiety, OCD, that they tend to kind of sometimes fall for this availability bias where we kind of weigh the information that we see as more strongly than information that we don't see, that we don't think of. We're just bombarded by all this bad news.
Yep.
Yeah.
I think that goes back to what you're saying in the beginning. Limit the news time. I think Jon was saying to 15 minutes once or twice a day. But I agree with that.
Yeah, that'll give you pretty much anything you actually need to know.
Yeah.
Okay, so what do you think about taking a more cognitive therapy emphasis, a la Paul Salkowskis and David Clark? And by that, what I'm going to read into it and say that would be less exposure and more kind of talking about risk, talking about perception of threat and overestimation of responsibility and things like that.
I have strong feelings.
You do?
I know it's
never
a
have
shock.
strong feelings.
One, no, but I have a reason for doing that. Because I think that, if I'm thinking about doing cognitive therapy properly, the main thing I need to be doing is always addressing what are the cognitive distortions that are important for that client. And all the ones that you listed had to do with cognitive distortions that I don't think are the core of OCD, because I think the core of OCD, surprisingly, I know this will shock all of you, is tolerance of uncertainty. So in just the same way, if I have somebody who has social anxiety and they're worried that, if I go to a room, 3 or 4 people might not like me, 15, well, any therapist can say, well, okay, that actually might happen, 3 or 4 people. When I talk about do we care about those 3 or 4 people? That's likely. Suddenly, if I say I'm worried I'm going to get sick from touching a doorknob, now we're suddenly using this, well, what are the odds? And that's fine if I have a problem with estimation, but if my problem is I want to be absolutely certain, that is the wrong approach. So it doesn't matter how much because if I want 0 probability, I don't really care that it's 2% probable. I would always be saying, just like I've already said, coping with uncertainty means the worst might happen. How would I try to cope with it in a positive way? Not that I know I'll do it, but what would be the best I can do? Will I actually do that? Yeah, I don't get to know. I just hope I'll do it that way. So I would still be doing exposure, because I think a purely cognitive approach is not really addressing the issues of that person if OCD is the issue.
Yeah. Sony and yeah.
I mean, I think I'm cautious with cognitive therapy in OCD because it can function like reassurance, and I think that's what you're saying, Jon.
Thank you.
But I think there is a place for the core disastrous fears and those patterns of thinking rather than the content of the actual obsession. I don't like to get too much into content, but more kind of a global distortion, process that might be going on.
Yeah, Jason, you want to add anything?
Yeah, I agree with what they're saying very, very much.
Yeah.
So.
I just don't think you can talk someone out of OCD. And when in the research anyway, when cognitive therapy works, it's because they're doing exposure in, they call it behavioral experiments, but that's basically exposure. Exposure, I think, is really the best cognitive therapy, right? Because the whole idea is to help people to challenge their thinking and change their beliefs as a result of what they learn, even if it's, I can manage uncertainty, I can manage anxiety. So
we're doing cognitive behavior therapy and applying to apply the best set of tools for that individual's problem. So it's not an either or, it's which tools make sense in this case.
Yeah. Would you ever recommend using worry time when clients are worried about things like, what if I get this? What if my parents get this? And I guess worry time is like having a worry time or capsule time where they're, this is the time I get to worry for half hour or whatever it is.
I think it's really important to then, if it's children, to train the parents on how to respond to that, because worry time can turn into half an hour of reassurance getting from families. Everything will be okay, don't worry. So it can feed the OCD in the long term because it functions as like a half an hour to get into a compulsive pattern with families. So, I've used it with kids at times, but cautiously.
Yeah,
I agree with Sony. I don't typically align with that. I mean, I think I'd rather have somebody recognize the thoughts that they're having and how they can choose to respond in a different way, rather than spending certain times during the day where they sit down and practice worrying.
Yeah.
I know for myself, and I'm not particularly a worrier, but I'd be curious to ask all of you this personal question. For myself, if there's something that's really important to me and that I am concerned about and I'm worried about, I mean, if I'm working on it, it's more at the back of my mind, but I haven't really found it's all going to be turned off until this magic time where it's going to pop in my head. I think if it seems to me that it's something real important, it's going to keep popping up at free time. And I can decide, I'm going to address it. So I'm basically saying, I don't imagine worry time working for any problem that I can successfully like put that half hour aside and rest of the day, like, okay, no problems, no rituals, no nothing. Anybody else personally can do worry time that well?
No. And I think to a certain extent, I think it misses the point a little bit, because what's wrong with worrying? Why do we need to not worry? Why do we need to like encapsulate that to a certain time of the day? Why can't we be better at worrying in terms of being okay with sometimes we're going to worry and sometimes we're going to feel uncertain? That's, as you always talk about, John, that's just a reality of life, especially now, especially having to do with the virus. Why not be able to just kind of look at your worry and say, this is what I do, and this is what a lot of people are doing right now, and that's okay. I don't have to fight that. I think bad things come from trying to fight worry, fight anxiety, fight uncertainty. So I don't think I'd be a big fan of the worry time. I would just say, when the worries come up, and you can do that. You can worry.
And I think,
yeah.
Go ahead, Sonny.
I would say it's better to carve times in the day to do more productive things to address the worry.
Yeah.
Like interaction, getting engaged in something, than just sit and go in circles asking the same question over and over again without any real.
Yeah, I think all of us would agree. The only thing we might agree is that, given the choice between worrying and doing your work, it's like, okay, I'm going to let the worry be percolating and making a lot of noise back here, and give however much attention I can to my work. But that's not quite what they were talking about.
Well, no, I think that's a good point, is being able to, why can't you do both? You can still worry and do work. I always tell the example now, having a kid she's home from college now, but in her first year. Last year, she was applying, and it's pretty worrisome. I mean, not worrisome, but it's stressful, right? You got to, help with the letters and the applications go in, and you got to wait, several months to hear back. And you do think about it a lot, and you think about it a real lot. Where's your kid going to end up in school? What if they don't get in? How much is this going to cost me? And I always bring this up when I talk with my patients. Like, that didn't stop me from going to work and playing, music with my band and playing sports and doing my work at the university and all of that. You still are thinking about those things, but you're able to still kind of get on with your life, even though you have those worries. And I don't know.
You might not be your peak. But okay, that's life.
That's right. You can't always be at the peak. That's a good point too. There's another great question that I saw. Oh, from Dr. Jeff Szymanski. What is one thing that you've changed the most in your treatment over the last month? Great thought question. From our fearless IOCDF leader. A nice picture there on the screen. Very handsome.
Young looking.
How old is that picture, Jeff? Yeah, so what's one thing that you've changed in your practice over the last month?
I mean, I think in a way this whole session we've been talking is the answer to that question. I'm not doing outside exposures. I'm not doing chewing ABC gum. I'm not going into dumpsters, I'm having people wash their hands for 20 seconds. I mean, really, my practice has been majorly changed for this. Now, the problem is there's not a client where COVID-19 is not a part of it, even if that's not their, they have the fear of, I'm going to be killing people in the normal way, stabbing and, shooting, as opposed to giving them COVID-19. That treatment part of the same. But I think this session in a way is, here's how I've changed my practice.
I think within mine, I've changed. Obviously, all of us have gone to telehealth, but I think with the advent of telehealth, I've chosen to be a lot more flexible with time for a few different reasons. One is definitely parents being at home and carving out appropriate time where their schedule will accommodate that's more quiet for kids and family members because of everybody's always at home. I mean, there's no really private time. There's no private room that they're driving to meet at my office anymore. So that's a huge difference. And then also just, reflectively for myself, personally, I have family and kids, and having time to be able to balance all that and being able to help support the kids and the rest of the family, along with running a practice and seeing patients, it's been a challenge. It's been interesting to do.
Definitely.
How about going online? Oh, sorry, Sony, go ahead.
No, I was just going to say ditto.
Yeah. How about going online? What's that like been? Because I am not someone who's done a lot of online stuff in the past. That's been an adjustment for me.
I've been going online for many years now, so it's something I've been accustomed to, and I've actually continued to seek out HIPAA compliant, BAA certified sources that you can obviously do treatment on, and to me that's very important. I found pros and cons to it, and some pros, like you could have the window open to somebody's life, really. You know, I haven't really been in a lot of my patients' rooms or kitchens or bedrooms. I was cooking with a patient, 2 nights ago, and I think it was a great opportunity for them and, us to work on something, which we typically wouldn't have,
Right.
But the cons are I have only the window that I could see. So if I tell them to move left or right and there's somebody else there or something else going on, it's not always the most warm and comfortable feeling.
Yeah.
I think go on.
I know. I was going to say, in some ways, it's become a little more casual of a relationship, between
Exactly.
clients. They all ask how I am, how my family is. So it's kind of been, we're all in this together, and it's really nice to see that.
I have to say though that I'm not completely comfortable in all cases. Sometimes, but with doing exposure, I don't feel like. And it actually hasn't come up all that many times. People haven't been doing all that much exposure. I don't have a ton of exposure cases right now. A lot of it is more kind of, other stuff. But I don't know, I'm a little bit concerned about, like, will patients do the kinds of exposures, will they do it in the way that I would want them to do it if I'm sitting right there with them, than if we're online? Like, it's easier to cheat. And I guess I get concerned a little bit about that.
I think, I think in a way, patients cheating, that's on them. And I way prefer doing it live, and I feel like it can be more effective live. However, I said, once I moved to California and I've maintained a practice that's about a third to half online anyway, I actually can get them to do, it kind of shocks me in a way that I can get them to do horrible exposures while I'm here and they're there. So I still, given the preference, would do it here. And certainly, I wouldn't want to take certain cases of certain severity. I wouldn't want to see them online because I would worry about it. But it actually works surprisingly way better than I would have thought. And I've seen some severe cases do very well. And I'm not sure with the cases where it's the most trouble that I wouldn't have the same trouble in the office. In the past, if it's going to be somebody I think is going to be pretty resistant, I did not want to work online with them because I just felt that in person would be better. But I don't know how much better. So yeah, I think it's surprisingly better than you would think. And the being able to be in their house, like, okay, we're going into silverware now. That's works out pretty well.
Yeah. Yeah, I mean, people on the comment board are pointing out that this is going to be the wave of the future. I think a lot of people are already doing it, but it'll be interesting to see how this finally maybe tips the scale, and we're doing this a lot more. It's less costly, but I guess there's also some cons to it as well. Let's see. Oh, and people are pointing out, I mean, maybe this is something that we can talk about, doing this across state lines. And also just insurance coverage, I think, is kind of a mess. And doing it across state lines, I know the APA and the state boards are trying to work out something where, if I'm in North Carolina and I'm doing teletherapy with someone in Virginia, they're paying me in North Carolina. The money's going into the North Carolina economy rather than the Virginia economy. The Virginia State Board gets upset about that. I think that's something that needs to be worked out so that we can do this interstate. Insurance companies, someone's pointing out, insurance companies in New York don't seem to be adhering to the law requiring coverage for it. They're interpreting it differently. So it sounds like there's still some things that need to be worked out.
Yeah, there's the legal part and the clinical part. And I think the clinical part's a little way more straightforward than the legal part, unless we're really strong advocates, is out of our hands.
Yeah.
We wouldn't want good clinical work to get in the way of political stuff now, would we?
Absolutely not.
Yeah, hopefully states continue to be more flexible about reciprocity. Yeah, it's true. I don't know, other questions, other thoughts that you guys have?
I was going to bring up something about, as a therapist, psychologist, clinician, just about our own anxiety in this space. I know I had two therapists in the past few days actually approach me in like the concept of like imposter syndrome, and I think that's been brought up in some of these conversations. Just the whole idea of how can I help patients when I myself am nervous or anxious or have a family or otherwise in this space, and I think it's a real thing to have a comment or a thought on, and in terms of, we all feel to a certain extent nervous in this situation. And I'm not sure what you guys think, but.
I think I'm only an imposter if I'm trying to pretend. No, I'm serious. Like, what you're saying is, there's anxiety. I'm not particularly scared of getting it, but I'm doing all of these procedures, and so I am taking them that level of seriously. So I'll admit it. I think if I said like I'm not doing it, it's kind of it's like, why should I be? I think saying that I'm willing to get it in the sense of like, because there's a beyond a limit that I can't do anything. I don't know how that makes me an imposter. Having anxiety, that doesn't make me an imposter.
Okay.
An imposter if I say, yeah, I handle this perfectly. I'm not anxious about it at all, and I just do this stuff without a thought. Okay, well, yeah, I'm lying, so I guess I'm an imposter.
I think that's what they were alluding to, as.
Maybe, I'm not sure, I guess if I was taking procedures that I'm not recommending to clients, that's kind of an odd situation to be in. And I've always encouraged therapists, for me, and I think for Jon at least, I don't know you guys, it's like, before this, it's like, if you're not willing to touch the toilet and stick your hand in your mouth, I don't want you working for me, because I believe whatever we're doing, I expect, whatever we're having them do, I should do. It's not like there's a double standard, like, I don't need to do this because I'm afraid. It's like, if I'm having you do it, then I should be willing to do it.
I entirely agree. I think anything you can ask a patient to do or anybody to do, you should be able to do yourself.
Absolutely.
Yeah. I wouldn't, I wouldn't say that I'm anxious. I'm concerned about a lot of things. Mm-hmm. More big picture stuff. I'm not terrified of. I don't want to get the damn virus, but I'm not living my life terrified of it. I'm concerned about like where this is all going, and like how are we going to know when to get back to normal, and actually, honestly, like as a sports fan, like when are we going to get our sports back, and how are the Tar Heels going to practice this summer so they're ready for the fall, because they're supposed to have a great incoming class. So I don't worry about that, but I do kind of I'm more like big picture, like how do we go forward from this? More than the personal stuff.
Jon, just as an aside to help you out with your sports problem, this is the time to do two things: buy a gaming computer and get into esports.
Yes, hockey, NHL. The NHL hockey on PS4 is ridiculously good, and one of my daughters plays it with me, and it's been awesome.
We've had that PS4. I'm an RPG fan. I'm currently on The Witcher, but okay.
Yeah. All right, people are writing stuff in, and actually I don't know can everyone at home see all the comments? I think so, because people are talking to each other, but it seems like people are saying that you can apply to any state licensing board for temporary ability to practice teletherapy across state lines during this crisis. That's wonderful. And that there have been relaxed, Andrea Batten points out, there's been relaxed HIPAA guidelines. I know that through my own work and through our work at the UNC clinic, and that's wonderful. So people are being flexible in the midst of all this, which is important. And hopefully, to some extent, that will continue, because sometimes I believe that goes a little overboard. Mm-hmm. Blah, blah, blah.
Medicare is allowing telehealth too, and they were very strict. So they've relaxed their guidelines, which has been great.
Yeah.
How are you guys handling your older clients? Because those are the ones I'm concerned about, who are trapped at home, who live alone, for example, can't get out. I think they've needed a lot of extra support lately as well, the ones who live alone. I guess same thing.
Yeah, I've actually helped two of my clients who are a little older get support with somebody to bring things to their house. So supplies and things from grocery store and whatnot. And but outside of that, pretty much the same.
Just kind of helping them get access to their basic needs. Some of them aren't tech savvy and don't order on Amazon or Direct Fresh or whatever. So.
Yeah, I mean, for people who are alone, it can be really difficult. My heart also goes out to people who have really young kids. I remember having young kids and like just a weekend of my wife and I just kind of but enjoying their company. Sometimes not very long, and now we have maybe months and months of this. And I have a colleague, they just had a baby and they have a 2-year-old. Also, that's got to be rough.
I think you bring up an important point. That's for clients as well as all of us, which is being compassionate enough to have mixed feelings. Because I think the time you have with your kids, at one point it's like, oh my God, but in some respects, it will simultaneously be a precious memory. Yeah. But it's both. It's like, because I think people have trouble with it being both. I'm remembering when my son was 2 years old. It was one of the nights where he was screaming, crying, and all my tricks had not worked. and it's like 20 minutes and he is still screaming, crying, and part of me inside is going like, Arr! And part's like, hey, hi, honey. And I go downstairs and we sit in front of the bay window and there's a giant moon. I stick him on my lap, and at this moment he decides to be calm. And I have part of me is like, oh, I just want to go to sleep. It's 2 a.m. And the other part was like, I will never forget this moment. And I think that's part of what the pandemic is. It's like, ah! And I will, but there are these other things that are really special. And it's like, I prefer not to do it in a pandemic, but all right, this is the good part of it. And it's not like it's either or.
I think that's so well said, John. And I think that reminding yourself on a regular basis about being like mindful in the moment is so important, and being able to sort of accept like that, whatever's going on, I've like screaming kids space right now myself, and being able to sort of recognize that actually as okay, this is sort of cool, this is going on, this is good, and I like that all the kids are active and together and sort of playing in the house. And this is not going to happen 5-10 years from now. They're going to be somewhere else.
Yeah, hopefully. But this is going to be something we're going to remember this and talk about it certainly for the rest of our lives. I mean, this is and might be a turning point in some respects in terms of the rest of our lives. Who knows how things are going to be going forward, but this is, people are talking about this like the worst crisis since World War II, which changed people's lives. We'll have to see how things go, but no small matter. Can we get back to business a little bit? So people are asking about hypochondriasis, health anxiety. Do you recommend an exposure approach? Like worst case scenario scripts, imaginal exposure, things like that, more than using a cognitive approach. And I guess there is some overlap with the term hypochondriasis is kind of passé now, but this illness, health, anxiety stuff now. So thoughts about that?
I always feel like jumping in, but John, you wrote the book on it.
Yeah, go for it.
You go first for a change.
So I do. I
that, by the way, because I know I'm going to agree with you.
Thanks. There. If you're agreeing with me, then I know I'm saying something good. But I do suggest that. I think you can get a lot of mileage out of the 3 main types of exposure, right? You can do imaginal exposure to thinking about either that worst case scenario, I have the virus or I have cancer or whatever, or even the exposure to uncertainty. Maybe I do, maybe I don't. And I've been to 10 doctors and they all tell me no, but some of them look at the floor when they tell me, and some of them say, well, we should watch that more carefully. So I think we can do imaginal exposure. We can certainly do in vivo exposure to reading about the illnesses. We can do interoceptive exposure to provoke if they're body sensations that trigger the distress. And then, as we've been talking about, I think staying away from sources of information about illness, looking up stuff, going back to doctors over and over again. I think of hypochondriasis as really part of the OCD, spectrum. It's funny that it's not in the OCD related disorders category in DSM, which I think is, well, I won't say it on TV.
A different conversation.
A different conversation. Yeah, we could have a whole nother hour and a half about the DSM. But yeah, I pretty much would think of that as being just like OCD.
Okay.
You didn't let me down, John.
All right, that's good to know. Let's see. Having gratitude. I see the guitars in the background. I didn't realize Jon Abramowitz jammed. Thanks. Yeah, we're the Loose Lucy's. Look up the Loose Lucy's on YouTube. That's my Grateful Dead cover band. And it sucks.
I didn't know about you.
That's very cool.
Yeah. Oh yeah, huge Deadhead. And it sucks not being able to practice these days. We have to get online and try to jam together, and then someone's internet goes out and all that stuff. So that's what I miss, probably the most out of all this. Is
as a completely superfluous aside, the dedication of my book has a Grateful Dead reference.
I will have to go. I read it in 2004. I'll have to go back and check it out again, John.
You will now.
Let's see. Don't you have health anxiety folks make regular visits with physicians, regularly spaced out and not in response to their concerns, or is that old stuff? I would rather not have my health anxiety folks go to physicians because I think they know what the physician's going to say. And if you made them take the bet, or as John refers to in his book, the gun test, they would say that my physician's going to tell me that I'm fine. And so why do you need to go if you already know what the physician's going to say? To me, that ends up being like reassurance.
Yep.
John, you have a little link to Loose Lucy's.
Yeah, I was going to say regular in the sense of okay, you have a yearly checkup, but nothing.
Yeah, right, exactly.
But,
yeah. Yeah. Loose Lucy. Euripides Ghost is a Loose Lucy's fan. All right. Well, this isn't supposed to be about me. So, but check us out. We're the Triangle Grateful Dead cover.
I like the way you did that. It's not about me. Check us out.
Oh, that's great.
Someone just posted our Facebook page.
The link. You can't see any of those posts.
Other questions, I don't know, the panel or people watching at home. This has been a lot of fun. It's always fun to geek out and talk about OCD. I love this stuff. This is great. Mm-hmm. Now that I'm stuck at home and not in having intellectual conversations with my colleagues, it's great to do this online once in a while.
That has been a loss. We've been doing conference calls with our staff just on a regular basis because we miss each other.
Yeah.
Yes.
Yeah. Patient has a spouse who has a healthcare provider on the front lines. He's afraid the spouse will die. What are your thoughts about imaginal exposure to the spouse dying? And I think that's going to be our last question. So it's a great question. How would you handle imaginal exposure?
If somebody worries about a family member dying, I would do that. And obviously that's always a painful exposure. But because kind of the emotional response is, I don't want to do that, life would end. And it's like, do you have kids? What do you want to teach your kids about coping with death and, all these things? You're stuck coping with it. I think coping with the loss of a loved one or yourself, that is horribly sad. And I think it's terribly sad to think about it, which is, I think, why we run away from it. We don't want to be sad. But, once I ask the question, I can't run away from it. So it's like, in a sense, it's kind of going through mourning beforehand. We know it's going to be a terrible year. We know a lot of terrible things will happen. But again, it's the reality. Yes, they might die from this illness, or they might die driving to work.
And it's a thought, and you might as well be good at thinking that thought. If it's going to come up, you might as well lean into it, and that's and learn how to experience it in a healthy way, rather than trying to push it away, which the exposure helps you to be able to be better at that thought, that unwanted.
I think one reason that sufferers, when they overcome OCD, are better than normals is because because they have learned to engage those thoughts, and normals are way better at denial. Like, if you have OCD, you're in heaven or hell. You're trying to run and can't, or you accept it. And that they would love to do denial and but they can't. And I think people who do denial in the end, it often will get them. And, often it's more individual. Now we're seeing on a societal level, what normal is. It's basically an ability to not handle all these things because we're running from it.
Jason, you were going to say something.
No, I think Jon covered it, but I think that people who have, OCD and especially who are in treatment have so much more practice at being able to learn to tolerate, irrational thoughts and uncomfortable thoughts. And now the rest of the world is sort of getting a much more in-depth taste of that, unfortunately, and it's a reality. And so, how do we work on that? And I think that's been a great conversation we've had.
Yep.
All right, and we do have one more question that now people are saying, this is a good question, I want to hear the answer to that. So we know that some clients don't respond to exposure and response prevention. How long would you do exposure with a client before you conclude that they are not responsive to the treatment? Great question, I agree.
I don't find people not responsive to exposure, but I do find that therapists will often do exposure with somebody before they're ready. That is, I really will spend a lot of time having the client really agree that they're willing to go for the goals of exposure. Because I've had clients literally not want to do the goal of living with uncertainty. So in that case, my treatment's prolonged. It might take me 3 months to convince somebody that there's really no choice. So I've seen a number of clients, it's not so much they're not responsive, they haven't really agreed to treatment, and trying to, in a sense, force them to do exposure, just blindly do exposure. Yeah, that doesn't work. I think that is treatment that's not really well done. So I think the whole trick with OCD is not, well, partially it's developed designing the treatment, but the real magic and clinical skill is getting somebody to emotionally really agree with it. Logically, it's easy, but to get them to emotionally buy into the treatment, that's the art.
Yeah, agreed. I think if the client's not responding, sort of the therapist's responsibility to take a step back and say, am I not hitting the right kinds of exposures? Am I going too fast? Am I not pacing it? It's an issue with the delivery, perhaps, and readiness.
I think just finding out where their stage of readiness for change is and being able to gauge that and working, I think both of you guys were saying, on their willingness and motivation. And, I think is the spot on direction. Yeah,
I mean, exposure works, right? I mean, when you are afraid of something and you confront it and you see that you can get through it and that what you're worried about doesn't happen, if you do that enough times, you're going to learn something. We all, have that experience. So I agree with all you guys. It's the art of how you're going to engineer that and making sure the person is ready to have that experience. I think it is time to leave it there. So I want to thank everybody on the panel. This was a lot of fun, a great discussion. Jon, Sony,
thank you.
And Jason, thanks a lot. And thanks to everyone watching who sent in questions. And if you didn't send in questions, hopefully you learned something. And thanks to the IOCDF for setting this up. So it's been a fun hour and a half.
Of course, thank you. You did a great job of working with us.
Thank you very much, Jon. It was great. And thank you to IOCDF definitely for setting this up. This is amazing.
Thank you, everybody.